play till the end and then take it when you need to take it.
So Virginia is telling us that Phoenix is where we need to go.
Okay, I can introduce you.
She said as a new medical director, didn't know
Laura
her name.
Dalton, she's here.
Laura
Want to meet her? She's
totally. Yeah.
I need to stay on a high perch because if I go down there, I'm not going to see her. We'll find Laura Dalton. The other thing is,
Laura Dalton.
There's a person who runs a private clinic now in Arizona. Her name is DeShawn Taylor, and I think I saw her over here.
Oh,
so let's introduce you to both.
Okay. Yeah.
Just follow me while I.
All right.
Oh my God! Do you want to know something? That was an emergency. Neither of us were supposed to go up there. Nobody could find it. Yeah, you were perfect. So we improvised. And you're like the shortest person in this office. I shouldn't be making fun of you. I think that's too nice. I'm pretty sure all right, I will tell you what, Laura Dalton has very long blonde hair. She's like a little Marilyn Monroe birthmark. And DeShawn Taylor is a black woman with a blonde, short haircut. So they're both very easy to identify. Let's enter the test.
All right. Definitely, yeah.
I found one of them.
Oh.
How are you?
Good to see you.
Robert Sarkis with Biomax Procurement Services. We do fetal tissue collection for stem cell research. This is one of my
Nice to meet you.
Wow.
We're supposed to introduce to DeShawn. Robert Sarkis with Biomax Procurement Services.
Okay.
We do tissue collection.
Sweet.
Good to meet you.
And they're looking for Arizona as an area where they might be able to
We're based out of the Los Angeles area, like Norwalk, Long Beach, that kind of area.
Okay.
And unfortunately, most of the providers in California are just saturated right now. There's already other TPOs working with them.
Yeah.
So, Phoenix area, Arizona seems to be an excellent second choice because it's literally just an hour plane flight away. So Devin mentioned you as well as the Planned Parenthood affiliate in Arizona as well as good connections to make.
Yeah, absolutely. It's been on my mind because I used to work at Planned Parenthood Los Angeles, and we used to have
Novogenics, I think, is the one that comes in, to do it there. Yeah. So you have experience with providing material for these purposes. Yeah, excellent. Do you do it in Arizona at all right now? Or?
Well, right now, no. And so my office, I've only been open for a year now. So we're pretty well established at this point, and actually, due to some things going on at Planned Parenthood, I get a lot of referrals from Planned Parenthood. So
interesting. Why is that? That they just can't handle the volume, or what is?
Well, I used to work for them, and then I left them, and so they're still recovering.
What's the nature of the relationship. Yeah, I don't know.
I mean, it's a good relationship. But yeah, I used to be medical director in Planned Parenthood Arizona. That's how I ended up in Arizona.
Okay. Oh, I'm good. Thank you.
So that's how I ended up in Arizona, because I went to work for Planned Parenthood. Because I was with Planned Parenthood Los Angeles, and also I had an academic position at USC. That's how I know Deb Nuatola, because she trained me as a fellow.
Okay.
So I have a very good affinity for the idea of tissue collection and research.
Right.
I actually had tried to pair with a company when I was at USC to try to do research, because they wanted to do stem cells.
Right.
But I couldn't get it through our IRB.
Oh no, the USC IRB?
Yeah, I could not
really?
get the USC IRB.
Don't they? I thought they have a stem cell program though that's already.
Right. Because it was abortion related, it was a problem. I think.
Oh my gosh.
It's frustrating how those.
That's what I've heard.
Politics get involved.
Yeah, surprisingly, especially in academia, right? It's on the one hand it's supportive, but we heard at NAF, so many people would say, good luck trying to practice abortion care at a university hospital or any hospital setting. No, thank you, but thank you so much.
Thank you so much.
So I know that I have a lot more opportunity now that I have the private office.
Yeah, because you're not responsive to an IRB at this point.
So as long as something's already IRB approved, then it's just a matter of working out the logistics to be able to do it. And so the way that my office is set up is every day of the week. So I'm an integrated practice with abortion and gynecology. So every day of the week, a patient could either, be in the office for a medical or surgical abortion or a well woman or whatever. So there's not concentrated days that are just abortion.
Oh, you don't have just like one procedure day.
Except for Saturdays. Saturdays is just a procedure.
That is a procedure day.
Overall, throughout the week, we are collecting. So it would just be a matter of, whatever the protocol would be for securing the tissue, and I know that there are some time limits. So, probably the day that we have multiple cases scheduled in one day, because I know storage and transport is
exactly. Yeah. What is your procedure volume like right now total?
We probably do. And also too, this is the time of year where things start to pick up, and then we peak like in the spring, like around May. So right now we average probably about 30 a week.
30 a week.
And then I would suspect that it may get to 50 by like the peak, 50 or 60 by peak season, which is like April, May.
April and May. Interesting. A provider from Ohio made that same comment to us when we were at NAF, although she said, I feel like she said that the fall was peak season for her, because she said, maybe it was spring, because she said people kind of get together during the winter when it's cold and dark and lonely, and then,
and then you get spring break, that kind of, but, and it's really by design, because I'm like an all-inclusive GYN clinic, so I'm not just an abortion clinic.
Okay.
There are other providers who, their volume is higher. And so,
what is your second trimester volume like?
I probably do. So are you talking like beyond 20 weeks, or are you talking about just outside of 12 weeks?
Yeah, outside of 12 weeks. It's good to know that someone is kind of consistently going up to 20 to 24 weeks, because especially when someone wants neural tissue, they're wanting, they want fetal brain, they want both hemispheres, and for whatever reason, like the sweet spot tends to be like 18 to 22 weeks.
Okay. I go up to 24 weeks. There is a practice that kind of preferentially gets the anomaly referrals.
Right. No, we want healthy tissue.
Okay.
Healthy normative.
Most of the patients that come to me are elective. They present themselves.
And you go electively up to 24 weeks. Okay.
So I would say probably for those beyond 20 weeks, they kind of come in waves, but I would say I average about 1 or 2 per month.
Okay.
But then there'll be a time where I'll have like multiple in 1 month.
And what about like?
So I generally do. I would probably say between 13 to 16 weeks. I'll probably maybe like 15, 20%, and then 16 weeks and up are probably about 10% of the rest.
So you might have of tissue.
But then I get referrals because I'm like Planned Parenthood has provider shortage. So depending on how many they get, they have a provider, then I get referred there. Direct referral from them.
So for example, like last week, how many cases did you have over 14 weeks, let's say?
So last week, over 14 weeks, there were 2.
Oh, only 2?
Only 2, yeah. And then...
And were those literally 14 weeks or 15 weeks? Or?
Yeah, they're 15 weeks. There
15 weeks.
There were 15 weeks.
Yeah.
This week coming up, I have a 15-weeker on Tuesday so far. And I have a 20-weeker starting on Thursday so far. And this week coming up.
And you're doing 2-day procedures for 20 weeks? Or?
Yeah, so I start the 2-day procedure at 16 weeks. And I do a 1-day procedure up to 16 weeks. And then I start 2-day procedure at 16 weeks.
Yeah, because obviously some of the parameters that we're working with, then tissue needs to be pretty much, pretty intact, because the more physically traumatized it gets, the more the stem cells get kind of mashed up and aren't available for collection.
Now the thing is, I don't do induction, so like my technique is a disarticulation technique. So there would have, we'd have to kind of talk about like exactly what it is that you're needing.
Right.
Because
breech position is great. We'll just throw that out there.
Part of the issue is it's not a matter of how I feel about it coming out intact, but I got to worry about my staff and people's feelings about it coming out looking like a baby.
There are a lot of variables going on.
So I don't. So yeah, that becomes an issue.
Yeah, that's interesting. That there's a kind of an issue with the staff to have to kind of protect their comfort level. That's so interesting. I mean, do you ever find yourself in a situation where like it would be easier if this case kind of wants to come out intact, but you are kind of like you have to make sure it doesn't, so the staff doesn't freak out? Or
that's one, and then another issue is Arizona is so conservative. I just don't even want to send a full fetus for cremation or any of that.
Absolutely, it's asking for trouble.
Right, they call her the governor out there, the Wicked Witch of the West.
Yeah, it gets, we have the people who do our paperwork for the fetal death certificates, they email us calling them babies. Baby this, baby that, baby so-and-so. And I'm like, that's creepy.
Yeah, that's so good. Wow. You know your environment. That's so well.
It's creepy. So, I mean, there are a lot of variables that come into play. Now, for example, if we have a patient who signs the consent, then we can have a conversation about we're going to do some additional preparation to try to have a certain thing occur, right? So I mean there is some flexibility in it. If we're preparing and we know and the patient wants to be a part of it, then we do things accordingly.
Absolutely.
Right.
And it's
is that something you've done a few times already, or?
Well, I've done like procedures for anomaly. You just need a little bit more dilation, and they kind of have to get into labor. So I mean, the patient has to understand.
So the intact cases you've done have been for fetal anomaly, where they want to be able to like take pictures and footprints.
Well, we want to make sure that we can like provide some decent tissue for analysis, or it's a case of like rape or something, and we're trying to get tissue to provide for evidence. So I don't routinely do induction type procedures for bonding and that type of thing, but sometimes too, just the patient, the way that they respond to the medication, things
it just happens. Yeah, absolutely.
So that happens.
Do you DIG?
Yeah.
Starting when?
20 weeks.
Starting at 20 weeks. Okay. Because that's the other thing, because DIG kind of rules out.
It ruins the integrity of the specimen.
I mean, it kills the stem cells. That's pretty cool.
I mean, so the thing is, it's really, and then not really an issue because in Arizona, if the fetus comes out with any signs of life, we're supposed to transport it.
At any gestational age?
Any gestational age.
Is there any standard procedure for verifying signs of life?
Well, the thing is,
that doesn't go in a chart.
I mean, the key is you need to pay attention to who's in the room, right? And like, you know, because the thing is, the law states you're not supposed to do any maneuvers after the fact to try to cause demise. So it's really tricky.
Yeah, it sounds like it's real hard to navigate that bad.
Yeah, it's really tricky. So we do, most of the time we do DIG and it usually works. And then we don't have to worry about that because Arizona state law says if there's signs of life, then we're supposed to transport.
Yeah,
it's a mess.
Yeah.
So,
Gosh.
Now, I do know that the other providers generally are doing anomaly cases, not really purely elective. I think a lot of the elective cases go through Planned Parenthood and then the other private clinics. The other provider doesn't start DIG till 22 weeks. I mean, again, there's some flexibility. I mean, I don't have a board to explain
Right.
to. So there's someone who's wanting to participate.
Absolutely.
Then, we work through it. But I mean, research shows that DIG doesn't make the procedure easier in someone who is well trained. But I have to tell you anecdotally, my biceps appreciate when the DIG works.
Really? It's in the biceps when you're doing a D&E?
It does not take me any longer to complete the procedure, but it takes more force.
Really? What is it when you're doing a non-dig D&E? That's where
It takes a bit more, yeah.
Wow.
So I remember when I was a fellow and I was trained, I was like, I have to hit the gym for this.
You have to go to the gym in order to do it. What age? When does it start? What gestation does it start getting really difficult? Like it is like a workout.
20 weeks.
At 20, that's when it becomes difficult.
It can get difficult.
Wow.
Now, ideally, you want to have the best amount of dilation as possible. So I think, again, it really kind of comes to in someone who's choosing to participate, we might just take a little extra time, to make sure that we have the dilation.
Right.
And so a little more time on the front end for, a quicker, easier procedure on the back end. If I'm not going to be doing just articulation, which I would normally do.
Right.
So. Reach makes it a lot easier because, but the thing is, there's still going to have to be some decompression of the calvarium for it to come out. So.
Interesting. Because Deb had mentioned to me that if you're doing, there's dilation that happens as the case goes on if you're extracting from breech, and then at the end that if there's you do it enough, and so then the calvarium can come out intact.
It requires, especially if further along, it requires a good amount of dilation. And so, for the most part, we're going to start the procedure before we get to that point. So it's really like, in order to get you an intact calvarium, the patient's really going to have to go into labor.
Oh, it's going to have to be essentially a D&E or essentially an induction.
Yeah, because generally, especially in a breech presentation, everything's going to come out and the head's going to get trapped. That's usually what's going to happen. And so generally, then we just take forceps and, do the rest. So, ideally, the patient would have dilated in the E-face enough that it just all
right. I mean, that's what Deb had said to me was that if you've got it starting from breech, that there's increasing dilation as the whole extraction is going on, so that by the end of it, you can evacuate an intact calvarium.
Potentially.
But I'm sure. I mean, every woman is different. Obviously, every patient is different, and so.
For the most part, in general, unless there's like complete dilation that's going to allow the head to come out, there's going to be some level of decompression on the way out. Even if I have not completely, if I'm not using an instrument to try to keep it. But again, in a patient who, is consenting to that, then,
to an induction.
It might take a little bit longer.
Yeah. Yeah.
So I mean, I think it's worthwhile to explore.
Yeah, definitely. Do you? I mean, and we return a portion of our researcher fees to the clinics and private practices that work with us. So just because if we're gonna come in and do all that, we want to make it worthwhile for you and make sure that it's a partnership that that benefits everybody.
Yeah.
So I mean, so that's all stuff to talk about, kind of how to fit all the pieces together. But I mean, it sounds like
I'm definitely interested. So that's what you guys are more interested in the later, or
definitely. I mean, it's every research project is a little different. I mean, I know stem cell scientists who use first trimester fetal brain, and that happens to be what their protocols call for. But typically, if they're getting neural progenitors, they want from later in the second trimester.
Because I remember there was one that I was doing where they really wanted, as best as possible, to get an intact fetus.
Oh, the whole intact fetus.
Yeah.
They wanted the whole cadaver.
Well, but this study that I was trying to get through, they wanted first trimester, but they wanted intact. So that I was like,
Yeah,
the research needs that vary.
Everybody's got a different experiment that they're doing, and so the custom requests are just so highly varied. So that's why really, from our perspective, what we're looking for is somebody who has the capability of that they regularly practice up to 20 to 24 weeks, and so that way we know that we've got that range of gestations available to fulfill whatever the orders are. So yeah. Now, are you friends with Dr. Laura Dalton? Because that was the other one that Devin mentioned we're trying to plan.
Yeah. So basically, she's the medical director of Planned Parenthood in Arizona, and so there are windows of time where they have provider availability to do the later cases.
Okay.
When they don't have the provider, then
they send them all over to you. Gotcha. So
there
really,
are some patients who will present there and then get referred to me. Then there are the patients who will come directly to me.
Yeah. So I feel like maybe what we're looking at then with Arizona is, I feel like you guys are a package deal, maybe.
Yeah, absolutely. You guys have that partnership already.
Yeah.
I mean, well, I don't get along with the CEO.
Oh,
That's why
really?
I'm not here anymore. But I think on a clinical level, there's, that most patients get referred to me for whatever reason, because they have confidence because I was their medical director. So there's that relationship. It's not a formal relationship.
Right, but it is a practical one, which would be ours as well, I think.
Yeah. So I think if it is that you're looking for non-anomalous, then it's going to be Planned Parenthood and me probably.
Yeah.
I mean, just for altruism and research, there is another provider who goes up to 22 weeks, and she does by induction.
In Arizona?
Yeah. She just increased her gestational age to 22 weeks, and she tells me that she's doing it by induction because she's a family medicine doctor. So.
Where is she? So this is not an outpatient clinic though?
It is.
Oh, it is.
Yeah. So she's
is it in Phoenix
Camelback Family Plan.
Camelback. Okay.
So you might want to reach out to her.
Are they here at this meeting?
No, because she doesn't have a Planned Parenthood or an academic affiliation.
Okay, gotcha. Wow.
So, just for completeness,
let me be sure to give you one of my cards right now. So I
changed purses, so I don't have mine.
Okay.
But I'll definitely take yours.
So we're at booth number 207. We'll be there all of tomorrow and the next day. If you don't happen to see Laura around here, do you, or Dr. Dalton?
I saw her earlier. I was over on that side, and I saw her. I don't know if she's moved. You said booth 207.
207. Yeah, there's a panel right on the back for you.
I mean,
It sounds like the exhibit hall is not too big this year, so I think we'll be easy to find.
Yeah. Here we go.
Oh, we got it. Oh, we got it. Yeah, we got it figured out.
Okay, so cool. But But yeah, I feel pretty good. I mean, my market share of the abortion services it continues to increase. So
Interesting.
it is very interesting to see how it all plays out.
And is Camelback, they're located in Phoenix as well?
Yeah.
Wow.
So she's been in business. She's been in business. Gosh, I don't know how long she's been in business. I would say probably 7 or 8 years, maybe.
And your Desert Star Family Planning is the name of your practice. Okay. Yeah, I mean, so I'm feeling like Arizona could be really good for if we, I mean, we could literally do, so one of our procurement techs. We have a few other techs as well that are part-time. So what we would do, I think, is we would just fly one of them out to Arizona for half the week, to Phoenix, and they could hit, Planned Parenthood one day, Camelback the next day, your clinic on Saturday. And
it used to be, because I was talking to Laura today, because it used to be when I used to work here, we actually used to, well actually, you know what, it still might be, because she was telling me that in Phoenix, they pretty much at this point kind of schedule the patients like one day a month for those cases, for the 2-day week.
At Planned Parenthood? Interesting. So we should figure out what that day is and make sure that that's our procurement day. And then, I mean, and realistically, that's an even better use of our time then, because then we just know, like, we're going to get 20 cases that day of exactly what we want. So
I don't know what the volume is at this point, because like for me, there is a window that generally I do these cases. I generally start Thursday and finish Friday, just based on my schedule.
Okay.
So, but I don't know what their schedule is.
Yeah.
So it could be possible where you can like kind of come hang out and be able to hit both places.
Yeah.
But it's really hard to say.
Just based on this.
It's exciting. Like I said, it's worth looking for all the details.
Yeah.
I'm excited, I think.
And in abortion patients, I have found, I've done research with abortion patients in my fellowship, and they have this level of kind of altruism to know that, okay, they're having the abortion, they feel some kind of way about it, but then to know that, like, there's some other benefit.
There's a greater good that can come out of it.
A lot of them do choose to participate.
Yeah, it's all about I think the framing is very important and very very helpful, I think. So that's
so I will come by there and I'll have cards by there. I'll have my cards.
excellent. Okay.
Definitely come by.
Definitely. Well, it was very good to meet you, and we'll speak more in the future.
All right.
Thank you for talking to us. We appreciate it.
Thank you so much. Yeah, good to see you.